Welcome, everybody. I'm going to be the moderator for this webinar, and we have got one other special esteemed guest waiting to come in, but until they come in, we thought we may as well start. So our first leading question for all of this is, let's talk about biohacking versus evidence-based medicine. So how do you navigate the pressure to adopt the latest trend while staying rooted in clinical data? And this question is for both of you.
So I think I believe in evidence, and I don't dismiss the new things or the new concepts which are coming, but they have to be backed up with the real data research. And first of all, the most important thing is that we have clients, we have patients, we have people at the other end. So there could be a lot of generated hype regarding anything which is new and coming. But for me, I think most of important thing is that, safety is there, and do everything based on the evidence. I would love to see the clinical data. I love to see the outcomes. I love to measure outcomes. If the outcomes show that even in smaller amount, something is working for a person, so it has to be a personalized approach. I don't believe that, if there's a hype regarding one of the biohacking, any technology which is coming, it will work for everyone. So it has to be evidence-based.
So yeah, I'll add my 2 cents to that. First of all, biohacking and evidence-based medicine, they're not mutually exclusive. I think they can both exist in the same space. It's really interesting because, when we talk about evidence-based medicine, sometimes we forget the levels of evidence and also the fact that clinical observation, what we do day to day with our patients, is in fact a level of evidence, right? We're treating patients, we're seeing outcomes, and we're gathering a lot of data. So I think that sometimes people might think, well, if there's no double-blind, placebo-controlled, randomized studies, it doesn't work. And in real life, it's not always that way. And especially in the longevity field and, quote unquote, the biohacking space, we're seeing a lot of clinical experiences that are occurring at a faster rate than the academic research. So I think we need to understand both, and definitely there's a room and space for them. And I think as clinicians in the longevity medicine space, we're really in charge of gathering a lot of that data, those observations, because again, the field is moving really fast. And there's a lot of people doing a lot of things before even some of the studies get launched. So, but that's still data and that's still experience. And I think we need to, understand it all and really absorb it. So.
And I think I will just add on, I completely agree. I think it's the definition or how we define longevity as well. The definition can be different for different people. Some people currently think that it's that when we talk about longevity, it's just extending the number of years. For me, maybe longevity is preventing, disease, maybe improving the quality of life and improving the healthy lifespan, increasing the healthy lifespan. I think most of the clinicians and most of the people in this field would agree that this is actually the right definition for the longevity. Why would you want to have a life of 120, 110, or whatever number you can give to a longevity if you don't have a healthy lifespan? So, and that can be, I completely agree with Louis, that, it has to be, it should be a population level data. It should be a population based outcomes, but a lot of work has to be done in this field. I think we are just in the start.
Perfect answers. I love that. And I couldn't agree with you more. I think, joining longevity and health span into, maybe let's coin a new phrase, let's call it healthgevity. As you say, there's no point being 100 or 120 years old if you're decrepit and you've got diseases and you're not enjoying yourself. That doesn't sound like something that anybody would want to do. So, having amazing kind of people like you in this space where you're focusing on not just the clinical data that you're seeing in front of you, but also real world experience, because it all happens differently outside of a lab to what it happens inside of a lab, and everybody is so uniquely different. And and that leads us very nicely into the next kind of topic. So, ladies and gentlemen, our experts here are using some of the most cutting edge and very trendy therapies that are out there. And as you heard them say, they're staying on top of all of these things. So let's bring it into a focus for now. So the focus here can be those for a moment will be like the GLP-1s, because these are all the things that are out there at the moment. And I guess before I ask the main question about the GLP-1s, what your own personal thoughts about them, and how are you using them in your practice, and how you kind of find them?
So I've been using it in my practice. We were the first few centers where we started doing these trials. Even when I was doing my PhD, which was a long time back, 2009, we were working on GLP-1 receptors, and we had the first few, like, the drugs coming in our clinical trials. So we have seen all the side effects. This is way back, beyond, like, when people even knew what Ozempic and all these names were. So we have seen these drugs progress, improve. The important thing is, I think it's a groundbreaking discovery. And if used in proper hands in a proper way, how they are meant to be, they are so powerful. GLP-1s, the cardiometabolic outcomes, the data based on data, and we have 2 recent trials. That's outstanding. But yes, we can discuss that later when others have given their opinion. I don't think the misuse that we are currently seeing, which is, vanity conception of these drugs, I think that's wrong. And that's if it's used in safe hands like any other drugs, it's amazing for the population they are designed to work in.
Yep. So I'll add to that. I agree, and I think there's no question about the benefits of GLPs right now, and not only in terms of cardiometabolic, but potentially even longevity, right? Inflammation, cognitive support, etc. My only concern, and I've been also using GLP-1s for a long time. My only concern is that I'm worried that I'm seeing a lot of patients bypass or try to bypass lifestyle changes in favor of GLP-1s. And I'm a big fan of lifestyle. Everything comes down to lifestyle. You look at the blue zones, you look at the people that live long and live healthy. And lifestyles, I tell my patients, lifestyles are non-negotiable, right? So my only concern is that, everyone wants the easy route, right? So I'll use the GLPs, I'll bypass having to exercise or having to eat well, etc. So I think that's really my message is they're great, they have their role, but we need to have them in the proper context, and lifestyles always have to be number one.
And even if you see the guidelines, for currently the guidelines suggest that for weight management, if you're giving the GLP-1, it has to be with the lifestyle modification. So you cannot do anything. There's no shortcut in taking these medications. This gives you enough time to actually get used to the lifestyle changes and have them implemented once the 2-year, currently because they have approved for obesity for 2 years. This is the time that you're given, that you go into that phase when you start enjoying what are the benefits of weight loss and change your habits accordingly. So yeah, it's according to the guidelines. If these drugs are used, they are amazing.
Amazing answers there, and I love both of those answers, because I couldn't agree with you more. Like, working with clients myself, you have to implement the lifestyle factors first. There is no quick fix. There is no limitless pill, which is going to make it easy, where you can basically continue making all the bad choices and just take a drug and it's going to nullify all of those bad choices and also give you the result that you're after. If it was, we'd all be walking around like Greek gods and there wouldn't be a problem. But obviously that doesn't address that. And I guess leading on to the question, or before leading on to the question, obviously you've got at the moment 3 different types of GLPs, obviously. So you've got like the semaglutide, the tirzepatide, the retatrutide, and they're all working on different things. Which are your choices at the moment? And this is my own question, just out of curiosity. Which ones are your choices at the moment that you use within your practice?
So it depends a lot in which country and which space you're working. So currently in UK, it's totally different. There are certain guidelines, and we have to work under the guidelines. And currently, the only drug that we have approved is 2.5 milligrams of Ozempic, 2.4 milligrams of Ozempic, and then also Mounjaro. But the BMI for that is above 35, or with other ethnicity is 2.5 minus for Asian ethnicities. But then again for special tier weight management services. So we are not allowed to be giving those drugs as frequently as we want to be giving them. And that's the reason that, but it's changing, because I think there's currently a submission is going to be done for the NICE guidelines to have these for other purposes as well, for the cardiometabolic outcomes and all those things. Based on the data, if you're asking my personal preference, based on the data, and we have done the trials as well, I think Mounjaro or tirzepatide would be better because of the percentage weight loss is much more than the Ozempic. So it will be a drug of choice if I have to decide.
Yeah, definitely. Great question. I'll add here. I agree. I think, first of all, I've had experience with the three of them, right? Tirzepatide, semaglutide, retatrutide. I think that overall, as Simon said, the tirzepatide data-wise, long-term is pretty good. Although I think the retatrutide is also going to be very up-and-coming and promising. In terms of a clinical perspective, I think it really depends on patient goals and needs. For example, if we look at the short-term weight loss goals, they sort of behave pretty similar. You can get very similar weight loss results if you're having someone in the first 3 months or so. Now, if you have someone that needs to be on this for a year or more, definitely tirzepatide is going to outperform semaglutide, and potentially retatrutide is also going to outperform. So I think we also have to take this into consideration: patient needs, preferences, and of course availability.
Perfect. And that nicely leads on to the next question, which is going back to the whole critics that are saying that the GLP-1s are a quick fix over long-term behavioral change. So how do you decide when a patient might benefit from a GLP-1 versus the lifestyle changes alone? So do you find that you're going to have some patients where you're just like, you just need the lifestyle, and then there are some patients where you need the lifestyle and the GLP-1 on top of that once you've got the basics in play?
So for the last 10 years, that has been lifestyle changes, and that has been in my specialty, which is the fatty liver disease. My patients are 80% diabetic and they are all overweight. We didn't have any choice without any approved drugs. We had only lifestyle management. And I, Louis, I personally believe, I'm a certified lifestyle practitioner. I do believe in lifestyle medicine. I think it has to be the choice given to the person sitting in front of you. Some of the people don't want to have these quick fix, and they are very keen, but then you have to be in the position that you guide those people. And it's just not telling them that previously how we had the guidelines that, lose 5 to 10% of the body weight and we will see you in 2 years. Nobody wants to be overweight. So you have to be there with them throughout their journey. There has to be so much support available that they are able to make that journey. Otherwise, what happens is the yo-yo sort of effect, that you lose weight and you gain weight, and again, the same thing. For other people, they have tried lifestyle and it doesn't work for them. So I think for those people who have, again, cardiometabolic predisposition and have high BMI, it has to be these drugs, because then they can have that percentage of weight loss, have the lifestyle along advice, and then have a journey which is so it has to be a personalized approach, and decision has to be jointly taken by the client and the physician.
Yeah, I think that lifestyle and GLP-1 are not mutually exclusive. They can both be combined. One thing that's very important, and I do understand, and I always want to make this a point of this: we live in an obesogenic environment. We live in an environment that's designed to make us fail. And I can totally understand how patients can have all these struggles. And I can totally understand how it can be hard for some patients to, make the changes based on lifestyle alone when they're watching ads, fast food, junk food ads on the TV every 30 seconds, and they walk out and there's Uber Eats and there's everything else. So I can understand that, right? Sometimes these medications can open the door and buy us some time and help make the lifestyles easier to adopt. I think in the end, what's really important is that as you progress with your patient or with your patients, that you make sure that as they're losing the weight, making the changes, that they really hold on to these changes. If I have a patient that's, on GLPs, they're losing weight, and a year later, they really don't want to make any dietary changes, they don't want to exercise, that's a sort of patient that we really need to address. Like, you're not really wanting to help or contribute to your health. So patient responsibility is very important, but definitely both of them can be combined.
And I will just add on that we have seen so many different type of patients, but there's one type of patient when you're giving them GLP and it reduces the appetite and all those effects that it has, they're still eating because of the habit of eating. And I always talk with them that, we have and they obviously have no GIT symptoms. And we always know, why do you have to eat if you're not feeling hungry? Why would you still eat? And in those people, we do see that, the percentage weight loss is less. And those are the people who usually leave the treatment and say it didn't have any effect. And then there are other people who actually change their lifestyle. And within 6 months to 1 year, they say, I think we have had enough weight loss and now we can manage on our own. So I think it's again, yes, it's definitely like, the person, it has to be a personalized approach that you give to their clients.
Great answers there, great answers. So this leads me on to my final question with this. So looking at GLPs through the lens of biological age, and obviously considering that all of them, whichever one you're using, are directly working on the leptin-melanocortin pathway, do you believe they have the potential to impact systemic aging process, or are there benefits that are more symptom focused?
So I completely think they would. And the reason is that my work for the last 15, 20 years on translational research is based on oxidative stress and mitochondrial dysfunction. And that's based like, the inflammation. And we have seen that, and it's not one data set, it's like, hundreds of data sets that, when you lose weight and you're in the healthy weight, the inflammation and all those parameters do improve. And that's why, the cardiometabolic spectrum is quite huge. We are already working on a study to see the effects of these, biological age, which is like, inflammaging. So if you're losing weight and the source of inflammation in your body is reduced and you're moving towards a healthy lifestyle, it will improve the biological age. But then there can be certain other things that we can discuss later after Lewis has given his opinion. I think how you manage with the sarcopenia and oxidative stress in that domain, like, how's the mitochondrial functional status in your muscle, it's very important. So I will let Lewis, give his opinion, and then we can have a little bit of like, another important point, which is the sarcopenia in these drugs.
Well, actually, that's precisely, I was just going to add that. I think that they definitely impact biological aging. They can, directly or indirectly through the weight loss and the control of the inflammation and all that. But that specifically to my point is the importance of, as you're having these patients lose weight, you have to emphasize addressing muscle preservation. Muscle preserving strategies are crucial because we know the benefits of having healthy muscle mass, especially in the latter years. So I think it's really important for patients that are losing weight, exercising, maintaining muscle mass, supplementing correctly, addressing this. There's many ways, many muscle preserving strategies, and we can go into mitochondria and all that. But definitely they do have a role, in the whole longevity stack.
And it's a very interesting theory that what we are seeing is that, when you have the muscle loss or the sarcopenia with these GLP drugs, this is different from the muscle loss that we see in the age-related thing, because, when you lose weight, with obesity, there is some extra muscle as well, which is not maybe useful. So, it depends. So there's a lot of research and work currently being done. Is the muscle loss, is the functional muscle loss, that are we seeing a defect in the muscle? Or it's just, is it the quality or is the quantity which is being reduced? So I think we will have these trials are still ongoing and a lot of work being done. We will be able to answer most of these questions that, but again, whatever the cause of, muscle losses, is it the functional, is it the quality or quantity? People or clients who are on these drugs, they need muscle strengthening exercise. You need to have a proper exercise regime, which comes under the lifestyle umbrella, so that, it's not the frailty that we are creating. It's a healthy person that will be there after 1 year or 2 years of the use of these drugs.
Amazing information there. So there was actually a very good question that just came up in the chat, which I wanted to bring up here. So you mentioned the oxidative stress side of things through the mitochondria. And obviously, at the moment now in the longevity space, particularly, there is a massive switch of focus onto the mitochondria and how these are the key drivers of longevity and health and all kinds of things, and that they're no longer just the powerhouses of the cell, which is quite nice to hear, because I thought that was such a rudimentary way of explaining them. So for both of you, do you have like a top 3 things that you can recommend, or supplements or lifestyle changes that you recommend to patients, where you can say this will help with extra oxidative stress that might be going on through the system, whether it's related to GLP-1 use or otherwise?
So your question is easy, because I thought you are going to ask me special biohacking tools which are known to increase, like, the mitochondrial biogenesis.
You can do that too. You can do that too.
But I think for me, I think the most important thing is to the diet. So there's a lot of diet which is like, antioxidative Mediterranean diet, having all these like, turmeric, all these antioxidative, the berries and all these, fermented food. I think these are very important in increasing the general health as well as reducing oxidative stress. And we have seen then avoiding of the harmful substances. It markedly reduces your oxidative. And I've done for the last 10 years, a lot of experiments in the labs when we are measuring the mitochondrial functional status with using different products. And we can see the changes immediately. And those papers are published there as well. Exercise. I think those would be the 3 main things. But then, if people and they benefit from infrared, near infrared, again, personalized approach, it does improve the mitochondrial biogenesis. A lot of data is coming. I wouldn't comment so much on the NAD and NAD plus, because I think we need still some more strong data, because most of these things cannot, go intracellularly. But they do have extracellular effects, which increases the energy levels. Let's have the data. Let's see, like, clinical studies showing mitochondrial functional status improvement using these things, and then it will be good. We should have those published data and talk about and discuss them.
So adding to that, and maybe diving a bit more into the whole biohacking concept here, but right, exercise, crucial, lifestyles, that's always the basic, the most important points. But from additional things that we can look at, if we look at peptides, for example. So we've been using a lot of the mitochondrial derived peptides with patients, and some of them, like the MOTS-c, SF31, humanin, etc. So they have this potential to help with that. And there's some, animal studies, some basic studies that have shown some benefit with some of these peptides. And there's also some studies where they've looked at biomarkers, right? Healthier patients, younger patients, athletes have higher levels of MOTS-c in circulation versus older, frail, sarcopenic patients and such. So we have that option of peptide therapy, which again, it's very personal, very individual. One of the challenges, and I totally recognize this, and I've been very involved in peptide education and training. One of the challenges that we have is that for a lot of these peptides, we don't have the large clinical studies, right? So it becomes more of a empirical, clinical experience, all these practitioners using them and connecting and networking and sharing insight on how patients are responding to these peptides. So I think that's one. There's other supplements that I definitely think can benefit mitochondrial health functioning, like urolithin A, definitely a supplement that could be of benefit there. We've been looking at many other things, even the methylene blue supplementation. And again, some of this can be debatable in terms of how beneficial or not. But there's definitely options out there. I'm a big fan of the infrared, of the, photobiomodulation. I've been doing that for a long time, so I think that also helps. So yeah, there's many things, and in the future, to be honest with you, and we're looking into this, I think we're going to have a point where we're going to be doing mitochondrial transplant therapies, both autologous and potentially allogeneic, even synthetic mitochondria as an option to enhance health span and even lifespan. So there's a lot of things that are up and coming.
Amazing. That sounds fascinating. Okay, and that actually nicely leads us into the next question. So I'd like to keep it just on the mitochondrial ones for the moment, but the next question being moving from one peptide to peptides more generally, and this one's aimed more for you, Dr. Louise. You have great experience with this type of kind of therapy? You know, as you say, you teach peptide therapy. Um, can you tell us what makes them so exciting and what are the most common types of peptides? But before you go into that,
Yeah.
talking about the mitochondrial peptides, obviously, as you say, you've got the MOTS-c, you've got the humanin, you've got the SS31. You've now obviously got two very big players that have come out recently, the SLU PP32 and the BAM15. These are obviously becoming more readily available. There is a potentiality of, as everybody does, they buy everything and then they take everything in one go. And linking that into the oxidative stress type of thing, we have got that very real potential of overclocking the system and overspinning the ATPase and things like that, which is just going to upregulate the amount of oxidative stress and all those other types of things. What's your main kind of recommendation for these types of peptides if people are looking to learn more or experiment with them in some way?
Well, I think the bottom line would be definitely work with a practitioner that has experience with peptides. Like you mentioned, there's always that risk of just really overstacking, taking too many things at a time, not knowing what is really helping or not. There's always also the risk of getting peptides from places that, are selling for research purposes, some online labs, where you don't know the purity, quality, etc. So I think working with practitioners that can work with you on peptide therapy is a first thing. It's a must. And there's many, I'm the first one to recognize there's many challenges with peptide therapies right now. Challenges from a regulatory perspective, what we can and what we can't compound or use in the States. For example, I practice in the States, right? So FDA regulations, some limits there. And again, some novel peptides that really are in paper look wonderful, but potentially don't have that additional data to really back their use.
Perfect.
And I
So
think I will just add, Mark, that you raised a very, genuine point that there's a balance. So, how much you want to, so mitochondrial dysfunction can be balanced very well from your own body as well. And that's like, all the antioxidative, and you don't want to disturb that balance. But there's a limit or there's a certain, threshold where that you are able to maintain that, and above that, if you do it, then it leads into chronic condition. So I think if you have to practice safely as a clinician using all these things and working in this field, what you need to do is, first of all, there has to be, as you said, a lot of collaboration between all the people working in this, sharing the data. The other important thing is you get the baseline screening done properly. You have, if you want to give supplements, first check the supplements. Currently, what is happening is everyone is going, buying, seeing it on the social media, thinking it's amazing, and then using it. And maybe overburdening your natural immune system and response. So you need to have the screening bloods done. If there's one message that has to be there, do proper screening, check all the supplements and things that you require. There's a lot of testings available. Then have a personalized approach based on that, and then follow up with the clinical evidence and sharing the data. Then, we are in the field where we can say that, these things are working.
I agree with you. I agree with you 100%. There's never any benefit to a shotgun approach with anything, because then, again, like I might have a patient come to me and I'll say to them, so how many supplements do you take? And they're taking like 200 supplements. I'm like, well, how do you know what's working? You don't, right? You don't know what's working, and things could be counteracting each other, and you're just wasting money, and you're probably causing more problems and then having to buy more things to rectify those problems. And it's no different from then taking every medication that a doctor's going to give you all in one go and wondering why you don't feel particularly well. So going back to that original question then, so for both of you, what what peptides are you excited about personally? And then what are the most common ones that you find that you use with your patients?
Sure. Do you want to go, Simon, or do you want me to answer that one?
No, you are the peptide
Okay.
expert, so I will let you.
So there's a few peptide categories, first of all, that are really popular or common, right? So we have some of them are the growth hormone secretagogues. So in that category, we have the sermorelin, we have CJC 1295, ipamorelin, tesamorelin. So all these peptides that will stimulate your pituitary gland to produce more growth hormone, right? That's been very popular for many years with people that are exercising. We know that as levels go up, IGF-1 levels go up, muscle mass improves, you can burn a bit more fat, you can recover better and sleep better, right? So that's one very popular mainstay category. And we still have some of them that are FDA allowed or approved, such as sermorelin. Then we move on to like the thymosins. The thymosins are more of an immune modulating category, and a very well-known thymosin alpha-1. And it's actually one of the peptides with the most clinical trial studies. It's been studied extensively, some regulatory approvals in other countries. So those are more for immune enhancement, which I think is very important. And then this is a totally separate talk, but if we look at immunosenescence and how it contributes to aging, right? A dysfunctional immune system is going to accelerate aging, and vice versa. As you age faster, your immune system is also going to fall into greater dysfunction. So those are another category there. We have peptides that are repair peptides, like just broad-based systemic peptides. Like probably the most well-known one is BPC. So BPC 157, which right now what we have in the States is a version of it called PDA, pentadecapeptide arginine. And that one is, again, very popular with just overall different types of repair that's been used systemically into joints, tissues. Then we have some other peptides like the longevity focused peptides, like the pineal-based peptides, epithalon, pinealon. And these peptides, especially epithalon, they were studied back in the day in Russia. They looked at telomere length. They looked at just overall survival in older patients. So we have that category of peptides. Then we have peptides such as, again, broad-based, such as GHK copper, which has been traditionally used in aesthetics, but we know that it has many benefits. It's anti-inflammatory. It can even have some anti-cancer activity. And then obviously the mitochondrial peptides that we mentioned. There's a ton of categories, and that's really interesting because the peptide field is just really ever growing. There's hundreds of thousands of peptides in our body. I mean, there's just a lot of things that are still waiting to be discovered or understood.
So, Luis, can I ask you a question?
Yeah, of course.
What are currently based in UK? What are the peptides which are allowed by the regulatory, authorities that can be given
in the US?
In UK and
Oh,
US as well.
That's a great. I'll be honest with you. UK, I have no clue. I unfortunately, we have practitioners that come to our events from Europe, and I know that in Europe there's a stricter guidelines, sometimes much more limited. Also, Europe, Canada, different places. In the States, I can tell you in the States we have two different categories, or well, three. We have peptides that are technically FDA approved. So those are like, for example, sermorelin, PT141 for sexual dysfunction, right? We have some of the we have some of these peptides that are FDA approved. Then we have other peptides that are allowed, that compounding pharmacies can source and can prepare for us to use with patients. And then we have peptides that fall under the, we can't use them, right? And to be honest with you, it's an ever changing, ever growing. It's a battle. It's constantly, the FDA is revisiting, revising. I mean, a few years ago, just to give you an example, a few years ago, the FDA totally changed the definition of a peptide. So, back then, peptides were understood to be these amino acid chains up to almost 100 amino acids. Then suddenly the FDA said, hey, you know what? A peptide is less than 40 or less amino acids. Anything over that is a biologic. So we have so many regulatory changes. But I mean, again, through our organizations, we stay abroad, we educate, we see what's going on. We work with pharmacies, work with compounding pharmacies try to, make peptides available, because the fact is anyone that's used peptides clinically knows that they work. A lot of these peptides are really good, and we see amazing results with patients. And a lot of peptides act really fast. So there's definitely that therapeutic benefit, and we just want to make sure, obviously, that we're in compliance with regulatory.
And just highlighting, is it the GLP-1s also sort of peptides?
Yeah,
Would you
yeah,
say
GLP-1s are
they are
peptides. No,
peptides?
totally. That's another type of peptide, insulin is a peptide, right? So there's many well-known peptides in the field. So yeah, huge market.
Amazing answer. Thank you very much for that. So just keeping it on that just for a second, you mentioned already the immune regulation peptide.
Yeah.
So the question here being, so from your experience, what are the most promising and well-researched peptides for supporting immune regulation and addressing chronic inflammation, particularly in the context of healthy aging?
I'm going to say the one that's definitely been the most studied in that context is thymosin alpha 1, TA1. I mean, by far, TA1 has been studied. It's been studied in cancer. It's been studied in chronic infectious diseases. It's been studied as a vaccine, like enhancing vaccine function. It's been studied in many different contexts. So I'm going to say TA1 would probably be the one, and which is really unfortunate because we were able to get TA1 in the States. Now we can't anymore, technically speaking. There are some ways to access it, but I would say from that immune modulation, TA1 is definitely the one. We've been using thymosin alpha 11, which is very similar, has had also some really good results, thymulin. But yeah, TA1, it's interesting, I've actually had patients where we've looked at CD4, CD8 ratios, and we've seen improvements in CD4, CD8 ratios with the thymosin, especially with TA1. So it's definitely helping the immune system. And I think it's probably one of the most promising to combat immunosenescence.
Incredible, incredible.
Yeah.
So obviously with that particular peptide, you say you've got thymosin alpha 1, you've also then got thymogen. So these are slightly different because we're now looking at a bioregulator peptide over
Correct.
something else. So for those that are here and listening, what is your clinical definition between the differences between peptides like BPC, thymosin alpha 1, and a bioregulator?
I mean, technically, I think that the difference becomes more, I don't know if I want to call it academic, not academic, more technical. Bioregulators are also peptides. A lot of these bioregulators are available orally, right? So they take them, they're sold as supplements. And I think that might be a major difference. The whole concept is that these bioregulators can restore function to glands, tissues, organs. But I mean, from a very technical scientific perspective, all of these are amino acid chains. So it really becomes maybe administration methods, maybe how they're sourced, and the whole idea that you take these bioregulators to try to restore functionality, like a functional peptide approach. But again, I think both traditional peptides, if you want to call them that, and bioregulators work well and have a role in patient health.
Brilliant answer. Brilliant answer. So the next question was actually for Dr. Jonathan, but he's not here. So I'm going to ask you guys this, hoping that you can obviously with your clinical experience answer this. We're moving away from the peptide side of things just for the moment. So ketamine therapy is having a moment right now. And for those unfamiliar, what exactly is it and how does it work, particularly in the context of mental health and aging? And that can be
I
for
mean,
either of you.
Dr. Simon, do you want to? I can talk, but do you want to? I don't want to forward the mic, so.
Yeah, so I don't usually use it in my practice because that's not my field of expertise. But yes, I know that its use is being now, widely available. People are really asking for it. And thinking about it like from clinical scenario, I think it will be having some benefits, but it has to be shown the context in which it is used. What is the benefit that we are getting and which disease we are targeting? And if it's just targeting the longevity or improving, the healthy lifestyle, is it this data strong enough? I
So
have my reservations, but this is not my field, and I don't use it in my any clinical practice. So yeah, Louis, maybe you have more experience.
I actually have a lot of experience with ketamine. I do use it in my practice. So it's really interesting. Obviously, it's an anesthetic, right? At higher doses, they use it in the OR when you undergo surgery and such. It's a dissociative anesthetic. In lower doses, it's definitely being shown to benefit multiple conditions, depression, refractory depression, anxiety, CRPS, complex regional pain syndrome, chronic pain, and other conditions, even PTSD. It's really interesting for many reasons. One is when you give it in the low dose protocols, it's extremely safe. It's very safe to administer, at a clinic, outpatient clinic. Obviously, you monitor patients, etc., but it's really safe. It can produce rapid results. So I've had patients where, they're on SSRIs, they have chronic depression, and they're not really seeing changes. You give them a few ketamine IV doses and they really improve dramatically. So that's really good. Also, a very interesting point, and I think it hasn't been explored sufficiently, but it probably will. Ketamine has shown to activate certain repair receptors in the brain. So, traditionally we would think of ketamine more on that, dissociative, just kind of like, because it's also been used, illegally as a recreational drug, right? But it seems that ketamine can also help restore certain function in the brain through the activation of these repair receptors, potentially even increasing certain growth factors in the brain. So that I find that really interesting. I like to combine ketamine therapy with some peptides and some other, integrative solutions. But so far, I've had overall a very positive response to ketamine therapy.
And Louis, again, me asking question instead of Mark.
Sure.
Any long-term research being done in this field, which, maybe in a collaborative research, and I'm not saying that it has to be randomized blind trials,
Sure.
but enough strong data which shows these effects with
Yeah,
the, neuroimaging and all those things?
I think so. I think there are some studies and some longer term studies, especially with the, depression patients, anxiety, PTSD, and even chronic pain, where there are seeing, long-term benefits. I think that with ketamine infusions, it's very important for patients to understand that they might need multiple infusions. I've seen that as the infusions progress, there's a cumulative benefit. You start seeing longer periods of symptom-free relief, etc. But yeah, there's studies that are looking at this long term. There's even in the US, there's even an approved intranasal ketamine version, right, for depression. So I think we have a good amount of data on ketamine and what it does at a psycho-neurological level.
Thank you.
You're
That's
welcome.
an amazing question. That was a lovely question. That was awesome.
Yeah.
So before I move on to one of the last questions, then take it to the chat, because there's a lot of questions going on in there. Looking ahead, what do you think the next 5 years in longevity medicine will look like? What will stay? What will go? What will fade? And what's going to surprise us all?
I think it's going to become more than a hype. It's going to become more than just like, biohacking, and currently where the field it is. I think it's preventive personalized medicine, or a therapy, whatever you name it. But it's going to improve a lot because we will have a lot of data. People are already working on the data, and we will have all the things which actually work in this area to be standardized. And I personally believe that all these things, so when we talk about technology and we talk about innovation and we talk about medicine, we are just restricting ourselves that we have to do the practice which is like reactive medicine. Currently, what we mostly practice is reactive medicine, symptom-based, generalized medicine. You get a person and you just try to deal with the symptoms. I think what longevity is, it's giving you a personalized approach based on data, and showing the improvement. So a lot of things will be coming. A lot of new technologies would be coming. I think AI is another thing. If you talk about next generation medicine, I think using the AI and the platforms based on predictive data, where you put all these results along with the genetic screening and all those, like, the peptide results, the proteomics. It will be amazing to see the peptides and the proteomics and metabolomics all being used as an interface at an AI platform, and then having a personalized approach. I think a lot of work is being done in this, and I think that will be the game changing for longevity, which is preventive medicine for my definition.
Yeah, I agree that AI is going to probably do an amazing job in terms of the assessment. There's so much data that we can gather now. There's proteomics, genome, biomarkers, etc. So I think AI is going to do a great job of just really giving that personalized assessment for patients and what they need, and really generate good predictive models. So that's that. From a therapeutic perspective, here's what I'm hoping. I'm not necessarily saying it will happen, but here's what I'm hoping. One thing that I'm really interested in is bioprinting, 3D bioprinting, organs, tissues. If we look at that concept, and I think it is advancing, in the future, if we can just replace old organs with functional bioprinted new organs, then that's going to have a significant impact on aging and on overall just health and functioning. So organ bioprinting, I'm really hopeful, optimistic on that. I think there's also going to be some advances in terms of stem cell therapies, induced pluripotent stem cells, cellular cell reprogramming, just bringing back, making old cells new again. That's going to happen. I mentioned mitochondrial transfer, synthetic mitochondria. I think that would be also very interesting to look at. And then some of the gene therapies, maybe again looking at protein expression, telomerase, clotho, and others. So it's going to be really interesting. The challenge is going to be probably how to integrate everything in a way that's harmonious, functional, and achievable for most patients to do.
And I will just add one more thing, that, currently longevity and all these things are considered to be for, a certain class of people, for elites. And I think that has to change. It should be like, something which can be easily taken up by everyone under a safety domain, and like, based on, again, the data, and having these platforms which will just make it easier to have the personalized approach with all the technologies. I think that will be very important. And hopefully in the next 5 years, we will see those changes.
I agree with you wholeheartedly. I think if you just look at the biohacking space alone, it is quite elitist in the way that it functions, and health is a birthright. If you want to get one of the best machines, you've basically got to be Brian Johnson and spend £2 million a year just to be able to get those advances. And I don't think it needs to be that way. I think it should be available to everybody, and not everything to everybody, because again, if you take everything, you're probably going to just, it's noise over signal, right? We need to make sure that we've got specific signals going into the body at the right times to create the right changes, and then move on to the next thing. So I couldn't agree with you more. I think they are absolutely amazing answers. I really do, and I'm very excited for this organ printing. We're all going to be up into our 200 and 300 at this point, I think. So moving on to some of the questions that have come up in the chat and come up in the Q&A box. One question which did catch my eye was about can you utilize? Now, I know that you can do this with tesamorelin, because that's what tesamorelin was obviously utilized for lipodystrophy, but can you utilize a GLP-1 in that same way?
So Luis, you want to start, and then I can
Yeah,
follow. I always lead, and then.
So I mean, for the like, did you say it was a question for lipodystrophy?
Yeah.
I don't see it working the same way. I
No.
think tesamorelin has a totally different mechanism of action from the GLP-1s. So I would say just right out, probably not. You would want to look at something like tesamorelin for lipodystrophy.
Mhm.
Yeah, I think I agree with that, because, there's a lot of data coming for the different uses of GLP-1s. Like, I think Luis mentioned before with the addiction and a lot of other And there's a lot of work done, and there's a lot of new drugs coming actually, which are being used for, I think, for different conditions, different aids. But we will need to see the results to show if the mechanism of action is currently. It's, you know how it is with the diabetes and the cardiometabolic conditions. It's a very huge spectrum. We have not been able to cure diabetes. We have just learned the ways to manage these conditions. We still haven't, with so much advancement and everything, we have not been able to cure. And when we are talking about will these drugs cure? No, I think they will just improve the quality of life. And the pathways are very, very difficult, because if we know there was one certain pathway, we would have drugs for all these conditions. We don't. We are like, mix and matching. We are using a combination approach to have the best quality of life.
And do we have any current glycanase data with the use of peptides, GLP-1s or otherwise?
So currently, we are working on a project, and hopefully we will have enough data. Maybe next year we will have the data with the GLP-1s. Peptides would be the Lewis domain. I think we will have some data, but I'm very hopeful that with the glycanage we will have the data. We have discussed, so if you're talking about case studies, yes, we have enough case studies to comment that it improves, the inflammaging. But if you want to have a data set which can really, show something, you need to have longitudinal points and then have all the other parameters. So currently we are working on that. And I think that will be an amazing work.
Mm.
Yeah, I agree. I think we're gathering data on peptides. We have some case studies, definitely. We have some particular case studies where we're seeing changes in biological age with some of these interventions and other interventions. It's really interesting. I've also been doing some of the plasma infusions and have seen some interesting results in terms of biological age with that. So yeah, I think it's a matter of time. It's not all when you're focused mostly on clinical, when you're mostly clinician, it's harder to devote some of the resources, time to really getting all of this data, managed, processed, accumulated, etc. But yeah, definitely that's where we're headed, and AI is really going to make that a lot easier now.
Mm.
I think with the GLP-1s, I think one thing we just miss is that, the body composition. If there are people out there who are like, taking GLP-1s, what will be amazing to do? We use, in my practice, we are using even MRI-based body composition to see the effects, like which are the muscles which are like, losing, which is the visceral fat, which is decreasing. I think it's this sort of data along with the clinical and all those markers, measuring the inflammation and inflammaging, and then describing them. That will be a huge difference. That will be groundbreaking work.
Well, on that note, I do know of some people personally in the biohacking space who are, and this actually comes from some research that they were looking into about microdosing GLP-1s, particularly retatrutide, because of the more metabolic effects that it can have. And by microdosing them, you are mitigating the potential side effects of the nausea and all that other type of stuff, but you're getting the profound positive effects from them. So like with the semaglutide, you'll get that dopamine neurological kind of thing. With the retatrutide, you're going to get that metabolic response. And they're doing the retatrutide microdose for that exact thing, the body recomp. So they're looking to obviously keep their muscle mass, reduce the body fat, and then also improve other markers that they've got as well. So that would be a very interesting thing to look at from a microdosing perspective rather than an all-out big bolus dose.
I think this is a very interesting question that you have just raised, because we see a lot of people who are doing it. But then, with all these drugs and even with the bariatric surgery, you reach a plateau. There's this point comes when there's no weight loss. And we have done clinical trials. So when we were doing clinical trials in phase 2, and we had different doses, and we were titrating with different, it can be similar to the microdosing. What important thing is you may be, mitigating the side effects or the GIT effects, but then the time it takes to reach the plateau, it's different for different people. And you don't want to reach the threshold very early. So you will see that the people have like 10% weight loss with the maximum dose, and then they're taking, I will just give an example, tirzepatide with 15 milligrams maximum dose, and so we are not seeing any change because of that they didn't go in the manner it was suggested. So
Yeah.
I'm not very fond of microdosing, because based on the data and the work that we have done, I think it's usually the threshold is reached quite early, and you haven't seen the maximum effect, which could be up to 24% weight loss. You have not seen it. So it has to be done under the proper protocol and guidance. You're not allowed under the guidance to do the titration dose like that. And that's when you're taking these drugs in the context of doing it self-medication. So it's still a drug. So it has to be done under the proper guidance.
Yeah, I mean, I think microdosing can be a double-edged sword, just because of that fact. I mean, you can get to a point where it becomes too low that it's not really working. So you really need to know how to work those protocols and how to look at, outcomes for them. But I mean, having said that, yeah, I mean, there are some patients that can benefit from microdosing. And again, it really depends on how low you go or what you define as a microdose.
Yeah. Yeah, agreed. Okay, so on that note, Alka posted this a little bit early on in the question box. Evidence takes time to catch up, and not everything can be measured in a timely fashion. He believes, sorry, that the evidence pyramid needs to be turned upside down. What would you say to that, and how do we collate our N of 1 evidence?
I think the most easiest way to collect evidence is to do collaboration, working together and getting their data. Currently, there's a lot of work being done. Having, evidence does take a lot of time, but you don't also want the wrong evidence to be there and then taking it as a trend. We don't know the side effects. We don't even know currently with the GLP-1s, what we have the data is, 3 years, 4 years. We don't know the 10 years, 20 years, the data that we will have. So what we can do currently is that we have to take into evidence, but then doing a lot of collaboration, working jointly, and then, then maybe changing how the evidence has to be shown.
Sure. Okay, so we've got about 5 more minutes to ask some more questions. So a lot of GLP-1 questions here. So for fatty liver and Q risk of 9.5%, if I start a GLP-1, should I rescan? I think this is a lady asked for a client. She has normal liver function, or is it enough to reduce her risk factors?
So we are talking, the fatty liver spectrum is very huge. So, if you are just having a fatty liver, in UK, 1 in 3 people have fatty liver disease. With the lifestyle changes, you can completely recover. If you do 5 to 7% of weight loss, you will have the fatty liver will, totally resolve. And even the liver fibrosis, if you lose around 7 to 10%, this is based on data, you can reduce the liver fibrosis as well. Now, with the GLP-1s, if your BMI is above 35 and you have the other metabolic conditions, which is defining of the fatty liver disease, you need to have one of the other metabolic conditions, then I think it will be very useful for you to have the GLP-1s, because it's currently being used in the trials. It's looking amazing. And we already have, one drug approved, which is not a GLP-1 for the fatty liver disease. But we are hoping that in the next 2-3 months, we will have a GLP being submitted for NICE as well for approval for the fatty liver disease. But BMI, if it's 25, 26, go for the lifestyle changes.
Perfect, thank you. Dr. Lewis, do you have anything to add to that?
Yeah, I mean, I think that I'm not sure if the part of the question was when to rescan. Was it when to follow up?
Yeah, it was. Let me just find that again.
So rescan has to be 1 year.
Yeah, that's what I was going to add.
Yeah.
Just,
So if the
wait at
liver
least a
scan
year.
or the fibroscan they're talking, it has to be, or even if it's an ultrasound, blood tests again, if it's FIB4 or something, you should be repeating it 6 months or 1 year.
Yeah.
Perfect. Okay, so I'm going to pick 2 more questions at random here. Okay, does oral BPC 157 have any role at all in oxidative stress management, I'm assuming?
So oral BPC?
Yeah, does it have any role in oxidative stress?
I mean, it can. I'll start off with saying I'm a bigger fan of the injectable BPC. I've seen it works systemically, works a lot better.
Yeah.
BPC does a few things. One of the things that it can do is upregulate antioxidant defenses. So there is that potential for addressing oxidative stress by upregulation of cell response. It's kind of like, I mean, it's not the same, but kind of like when you look at the sirtuin activation with resveratrol, pterostilbene, et cetera, it's really more of that activation process. So yes, but I mean, I'm not really that big on oral BPC, to be honest.
Yeah, I agree with you. I think oral BPC is great if you've got something slightly more gut related, because obviously if you're using the arginine base, you can go
Yeah,
straight to that. But BPC should be sub-Q'd for everything else, personally.
agreed.
I totally agree with you. All right. Last question. Okay, so how easy is it to target specific mental condition issues with ketamine control therapy like anxiety or OCD?
I mean, it can be very easy to approach and offer the therapy to patients, definitely. Obviously, you know, I'll make an analogy here, right? The way that we're looking at GLP-1s and lifestyle changes for weight loss, when you look at ketamine therapy for conditions like chronic anxiety, chronic depression, et cetera, there's also always that environmental lifestyle component, right? And that's really important. So ketamine is going to help. It's going to help reduce symptoms faster, maybe for a more prolonged period of time, but you also need to address what's going on with that patient. And interestingly, not only the environment, but the actual nutrition. You know, micronutrient deficiencies can contribute to a lot of these anxiety states. So even that needs to be looked at. That's why the functional approach has to be, you know, addressed when you're treating patients. But yeah, can ketamine help faster? Definitely.
Perfect. Perfect.
Yeah.
Well, I want to be very respectful of both of your times, so I'm not going to ask any more questions from here. So, ladies and gentlemen, I just want to say thank you to Dr. Louise and Dr. Sema for coming on and sharing their wealth of knowledge in such a broad spectrum of topics. I'm sure we've answered many questions here. So thank you, guys. I'm going to pass it